Ladies and gentlemen, dear friends, I welcome you to this lecture about delirium and early mobilization during the World Delirium Awareness Day. I hope you celebrate it in any way and make delirium more public, talk about it. My name is Peter Nydahl. I'm from Kiel. You see this picture of our University Hospital close to the Baltic Sea. It's a lovely city, I think. I'm a nurse and nursing researcher, and I've got one conflict to declare. We won a delirium research grant by the German Society of Intensive Care Medicine and Philips. I will come to this later on. Background. I think you all know this. Delirium is a cerebral decompensation and appears often in the intensive care unit. Prevalence in general is about 20% in elderly people in hospital. In the ICU, at least 25%, but there are a lot of studies reaching 60, 70, 80%. On stroke units, 25%. Interesting, during the last years, only 10%, likely by an improved care. And so they have less delirium. Palliative, about 80%, and in children, up to 84%. That's tremendous. And I think we have to pay more attention to the pediatric setting. Problem, delirium is not something that comes and goes, but increases risk for longer duration of mechanical ventilation or length of stay in the intensive care unit or in hospital. It increases mortality also after 1 year. Cognitive decline and the development of dementia are also risk. Worse rehabilitation after critical illness, for example, and traumatic memories being captured, tortured, things like that. And moreover, there is a dose-response relationship. The longer delirium appears, the more prominent are the risks. And 3 days of delirium increases the risk for mortality more than only 1 day of delirium, and 1 week of delirium, and so on and so on. Increases the risk tremendous, yes. Recommended for prevention and therapy of delirium is early mobilization. And here we are talking about this during the daytime so that patients can rest at night. For you who are not from the intensive care unit, we try to explain and report delirium more specific, as in former years. And Girard published a fantastic study about the phenotypes of delirium. And his research group found that this was a multi-response answer, that around about 80% of delirium episodes can be explained by hypoxia or shock, by sepsis, related to sedation, benzodiazepines, and so on, can be metabolic. Yeah, these are 80%. And there are some delirium episodes which are unclassified, who cannot be related to these 4 main groups. That means delirium in the intensive care unit is most often related to sedation or hypoxia and shock, sometimes also to sepsis. We have to keep this in mind. And when we talk about early mobilization, there are also different types of mobility possible. There's a very good paper, you know, the PETIS guideline, and also the paper written by Clarissa and her team. They included 70 studies with a broad range of definitions of early mobilization. So early mobilization on the intensive care unit can be passive for severe ill patients. That means bed mobility or neuromuscular electrical stimulation. It can be also assisted breathing exercises or cycling, functional exercises, pre-gait exercises, resistance, and also transfers from bed to chair, for example. And active range of motion, activities of daily living, also together with the occupational therapists, ambulation, marching beside the bed, and marching on spot, for example. So it has a long, broad range of possible activities. And it can also include cognitive exercises to make the brain mobile. Yeah, occupational therapists love them, and they are very, very important. So best would be to offer early mobilization in a whole concept. We call this the so-called Abcdf approach. And the PEDIS guideline, for example, recommends this. You will find on the website of the Society of Critical Care Medicine a lot of information about the Abcdf approach. It includes early mobilization and rehabilitation. Patients should be awake, participating, should have any way of assisted breathing on the ventilator or not, free of pain, anxiety, and stress, of course. You have to manage delirium, provide a good sleep hygiene, family participation, and best would be to have some kind of dysphagia management. So it's a whole complete concept. And PUN published, I think 2 years ago, great paper, including more than 15,000 adult critical ill patients. And the main result is the more you perform the Abcdf bundle, the complete bundle, the better will be the outcome of your patients. The time of mechanical ventilation decreases, pain increases because they proved a little bit assessed more for pain, but times in coma and times in delirium significant decreases, and also physical restraints. You see here the elements which are performed and the time of being on the ventilator. The more you perform the complete bundle, the better will be delirium and other outcome parameters. It's amazing. Problem: delirium is often a barrier to early mobilization. I can tell you as a nurse, it's not easy because patients, sometimes delirious patients, have special needs which are difficult to fulfill. I want to go home, or leave me alone, or do you think that we are here in a submarine or whatever? So it's sometimes they are in a different reality, and it's difficult to follow, of course, and moreover to fulfill their needs or wishes. And this is also not recommended. They do not follow commands, they are not compliant or sometimes combative, they are cognitive decline, they do not understand our instructions when we're talking too fast or to have long sentences. They are at risk of pulling out the lines and tubes, and we cannot leave them alone because they always need some kind of supervision. That makes it difficult for nurses, for example, and also physiotherapists and other therapists to mobilize these patients. Nevertheless, we try. There's one very exciting delirium literature. Sorry, there is one exciting systematic review meta-analysis by Haley. Let's get physical. So now I get it. About early mobilization and delirium in hospital setting. In general, it includes intensive care unit studies, but also on general wards. 77 studies could be included, and they found a very good data for delirium prevention. You can reduce the risk by half, we can say. So this is amazing. But there was insufficient evidence to draw conclusions about managing established delirium. So delirium prevention and mobilization is a good thing, but mobilization for existing delirium as kind of therapy of delirium remains controversial. We have not enough data for this. Yeah, and when you have a look about early mobilization and delirium in the setting of intensive care units and have a look on randomized controlled trials, you will find in a PubMed search this morning 6 trials. This is Schweigert, of course. He's famous, mobilization within 72 hours. And of course, duration of delirium, incidence of delirium significantly decreased. Stephen Schaller, now in Berlin, he implemented the SUMS protocol, mobilization within 72 hours and more days free of delirium. Schiavani, last year published also an RCT in the cardiosurgical setting, mobilization within 48 hours after the operation. And also incidence of delirium decreased on the 2nd day post-operation. There are also other randomized controlled trials by Brummel, mobilization plus cognitive therapy. Here you would think that would be amazing, preventive and therapeutically for delirious patients, but in both groups, intervention versus usual care, they had both equal days free of coma and delirium. Peter Morris also 3 times a day physiotherapy must be amazing, increased dosage, but in both groups, similar days with delirium. And famous Sabrina Ekman from Switzerland made intense physiotherapy compared to usual physiotherapy in both groups, similar days with delirium. So we have some promising data, but this is not stringently used, cannot be stringently proved in all studies. We have to conduct more studies and more meta-analysis. We tried this. In general, mobilization is recommended during the daytime so that patient can rest at night. But as a nurse, I can tell you a lot of patients become delirious in the evening. So mobilization, especially in the evening, may guide agitation, especially when patients become restless, support reorientation when you're sitting or standing and you can look around, where do I am, things like that. Maybe they normalize homeostasis of neurotransmitters in the brain and induce normal sleep. They don't need benzodiazepines afterwards for falling asleep and so on. So maybe a good idea. And what I found out, every 3rd to 5th out of bed mobilization happens anyway during the evening or night when the physiotherapists are not aware, they're not here in the ICU anymore, but when the nurses perform mobilization. So why not? We won this research grant. You see the picture left, 10,000 euro, that was great. And we used this money to pay the staff. We developed the idea that we have an additional mobility team that comes in the evening or stays after the afternoon shift and mobilize patients in a randomized controlled trial on 3 consecutive evenings between 9 and 11 p.m. On the bed, on the edge of bed, or standing, sitting in a chair, depending on what is feasible, what the patients like. And we had so much money that we can conduct this trial over 2 weeks. It was an international multi-center trial over 2 weeks, and we could include it 30% of all patients. Duration of delirium was a little bit shorter in the intervention group versus the control group, but this was not significant. The incidence of delirium was 8 in the intervention group and 13 in the control group. And this was showed a statistical trend, we can say. We made an unplanned post hoc analysis over the first 4 days, and this showed that we have a significant impact on prevention of delirium. But this is post hoc analyses are kinds of cheating, I have to say, and this is a little bit tricky. When we planned the study, we planned to mobilize patients on 3 evenings, but we didn't thought so far ahead because some patients became afterwards delirious, and we made a 28 days follow-up, so it can happen. Now we are more smart. Yeah. At all, we discuss this and other studies. We think mobilization in the evening is feasible and safe. It's not during the night, because at 11 o'clock, I think this is also usual in the normal population. But we have to say, some patients are not on the ventilator. We had 50% patients on mechanical ventilation who were also mobilized, but the severity of illness was a little bit low. So maybe we included patients with low risk. Contrary to multimorbid high risk, patients with a high risk for delirium decline mobilization more often. We had 15% of patients who declined mobilization because they felt fatigue, they had pain. Okay, you can handle pain with drugs and so on, but they declined. They had no interest. But these were the patients at highest risk for delirium. So maybe we excluded them too much. Prevention of delirium, maybe there is a possible impact of mobilization, but we thought about how long will mobilization will have a preventive effect. if you mobilize the patient for, let me say, 20 minutes on the edge of bed, what would be great? How long does this prevent from delirium? 24 hours, 48, 72 hours, or even longer? And is there a dosage intensity of mobilization important for prevention? That means, do we have to stand up to prevent delirium, or is sitting on the edge of bed enough to prevent from delirium? What about frail patients? We had some frail patients in the groups. Of course, would for frail patients, sitting on the edge of bed be enough? And for non-frail, it must be standing, maybe possible. And does mobilization really lead to a better sleep afterwards? Or does it reduce noxious effects by the surroundings, and the patients do not need benzodiazepines, for example? We didn't prove this because it's complicated. They need an EEG, and this will reduce the possibility of sleeping. So it was too large. But this is also an interesting question. And about existing delirium, we found no impact or a non-significant impact on existing delirium. So, but we have also to discuss, if you verticalize patients, what happens to a cerebral decompensation? So maybe the cerebral oxygenation reduces when you verticalize them, when you put them in a chair and keep them 2 hours sitting after a stroke, for example. We know that this is not a good idea. And there are some studies, the AVER trial from Australia, for example, which showed that you can even harm patients by too long mobilizations in the early phase after a stroke. So we must be careful. And I think we should measure something like cerebral oxygenation during mobilization would be really interesting. And do specific delirium phenotypes require specific mobilizations? So when we look again on the phenotypes by Girard and his team, we have hypoxia and shock. So is it a good idea to mobilize these patients when they are in a shock, when they have a low MIP, for example, when they have a low blood pressure, and you mobilize them out of bed? I think maybe you can even harm patient or increase the risk for delirium. For patients with hypoxia, I think it's a good idea because we know that mobilization in general improves the ventilation of the lungs, and this will improve hypoxia. COVID-19 patients, maybe not, because they have not so much resources for being mobilized. So maybe only short moment, but not an hour or things like that. If the patients have a sepsis, mobilization is feasible. There are some trials who proved mobilization in septic patients, but we have no data about the development of neurotoxins in the brain in sepsis. And of course, it's a question, when do I perform early mobilization? In the first day, when the patient is really severe septic, or after 1 week, nearly after sepsis? I think sedative-associated delirium will be improved by mobilization, of course, and also if patients have a metabolic delirium. This is seem to be plausible, meaningful if you mobilize them, and all other delirium episodes remain questionable. Furthermore, delirium and agitation, you know all the RUS score. If patients have a hypoactive delirium, if they have a RUS of 0 or below, of course, mobilization can be recommended, no question. If they have a hyperactive delirium with a RUS of +1, +2, a little bit agitated and restless, of course, mobilization can be recommended. But if they are very agitated or combative, of course, maybe they need a pharmacological intervention before to take them a little bit down. And then they can be mobilized after 15 or 20 minutes, for example. But first, they have to need something against pain or anxiety or whatever. Yes. So depending on the type of delirium, we can also think about the type of mobilization or not. Yeah. And we have to think about communication, especially when we are therapists or nurses. We know that delirium makes a cognitive decline, and it's proven by Green that delirious patients use less words and work out less information. They understand slower. That means for us, we should use short sentences, use the language, dialect of the patient, move and act slow, and so on and so on. So the communication during mobilization of delirious patients is also important, and I think can have an impact on the outcome of prevention or therapy of delirium. So in summary, mobilization as standalone intervention may prevent from delirium, but mobilization as part of a bundle is likely more effective. The impact of mobilization on existing delirium remains unclear, and do specific delirium phenotypes require specific mobilization? I think so, yes, because it depends on the phenotype of delirium, the type of delirium, hyper, hypo, mixed delirium, the RASS score. It depends on how long the delirium is existing or lasts already. I think if the longer it lasts, the more difficult it becomes. So if you perform early mobilization during the first day of delirium, maybe it helps better than later. It depends on the general treatment of delirium. What delirium management do we have on your ICU or ward? And it depends on prevention versus therapy, two different things. And we have more success with prevention. And that's also better for the patient, of course. So there are a lot of questions. And mobilization, of course, there are a lot of types of mobilization. Is it passive, range of motion? Is it cycling, for example? Is it standing or even walking on the ICU? May prevent more or less from delirium or have a therapeutic effect. The time point and duration, do I mobilize in the morning, afternoon, or even at 7 o'clock till 9 o'clock? David McWilliams, who was one famous physiotherapist and part of our research group, plans the next trial between 7 and 9 o'clock, not between 9 and 11 o'clock. So that may be more effective. We don't know. The intensity, the frequency, how often do we mobilize, and is it part of a whole bundle, may also have an impact on prevention and therapy of delirium. So there are a lot of research questions. I think mobilization, as a nurse, think it's a good thing to mobilize patients, but not 100%. So look at the specific type of delirium, what can be helpful now, and choose the right type of mobilization so that they can fit to each other. That's all. Thank you very much for listening, and enjoy the World Delirium Awareness Day. Good luck, and thank you all.